I want to introduce Michelle Barnes. Michelle is the Executive Director of the Department of Human Services, and she is the Chairwoman of the Behavioral Health Task Force. And we are having several of these listening sessions around the state to be able to hear from the public. So we're happy you're here today. I wanted to start off by letting other members of the Behavioral Health Task Force who are sitting around this table to hear testimony have an opportunity to introduce themselves. So I'll start over here. Oh, and if you could use your microphone and turn it to green, that would be great for folks that are joining us via the web.
My name is say my own name. My name is Aubrey Boggs. I'm Colorado's Ombudsman for Behavioral Health Access to Care. I also have my new deputy, Rebecca Swanson, with me here today, and I am part of the Safety Net Subcommittee.
And my name is Carly Salen. I'm the Assistant Program Manager for the Crisis Intervention Response Unit, and I oversee the Competency Pilot Case Management Program and the Bridges Program, and I'm on the Long-Term Competency Subcommittee.
Is it green?
Didn't go green. I'm Nancy Vandemark, and I'm currently unaffiliated or affiliated with myself.
And I'm Glenn Most. I'm with West Pines Behavioral Health and SCL Healthcare, and I'm on the Behavioral Health Task Force.
I'm Michelle Barnes. I'm the Executive Director of Department of Human Services. I chair this task force in addition to running human services for the state. And I'm just so glad to see all of you here. Thank you. Whether you're here to testify or here to listen, it's really important to have everyone here, so thank you.
So just to make a couple more remarks, I think we're in a really important time in history where we have the opportunity to take a look at the entire behavioral health system. This is a priority for Governor Polis. It's why he created the task force. He's let it be known that pretty much everything is on the table. He also gave the Colorado Department of Public Health and Environment the goal of reducing suicide. He's given every department 3 or 4 priority goals. He calls them WIGs, wildly important goals, and that's one of ours. So we have joined with the Behavioral Health Task Force and many of the other cabinet members, Division of Insurance, Healthcare Policy and Financing, and we're trying to determine the levers that we have as state agencies to really help improve the system. And such a big part of that is hearing from residents to understand how this system is or is not working for you. So we look really forward to hearing the testimony today. And with that, I'm going to turn it over to Summer, who's going to talk about the agenda and give us some instructions for the day. Thanks.
Thanks, Jill, and good afternoon, everybody. My name is Summer Gathercole. I'm the Senior Advisor for the Behavioral Health Task Force. One thing before we go into some housekeeping rules, I'll just let you know that Valerie Schleck is with us. She is on the Behavioral Health Task Force, and she's participating by Zoom. So I just wanted to let you know that as well. We have about 12 or 13 people who are registered to testify today, and as Jill said, we really appreciate everyone being here and your willingness to share your stories and your experience and give us those recommendations, because it's really important for us to know. We are going to ask you to keep your remarks to about 5 minutes or so. It is not a hard cutoff, so we have some flexibility there, but I will start waving my arms when we're way over time. So just please try to keep that in mind. And the other thing that I'll just share with you today is that today is really about kind of listening to your thoughts and your recommendations and what we need to be thinking about moving forward. So I know we are hearing a lot of challenges with current situations, and we recognize that we can't ignore those. At the same time, what we're building is a blueprint to deliver to the governor in July of 2020 for implementation. So I think bringing some of those issues to us is important so that we know and we can acknowledge them, and we can think about them going forward in terms of what those solutions are. And at the end, we'll share kind of the Ombudsman's number and information so that you can make sure that if you have a problem right now, that you have a way to reach out. So with that, we're going to go ahead and jump right in. Monique McCullum is the first person who's scheduled to testify. Are you here with us? Great. Monique, if you want to come on up and sit at the front table here, that would be great. Just as Monique's coming up, I'll share a reminder that we are recording all of the testimonies. We have a media release form at the back of the room. If you have not signed it already, if you can sign it and submit it to me, that would be great. If you do not feel comfortable being recorded, that is completely fine. Just let us know so that we can stop the recording, because we want to be mindful of that and realize that not everyone is comfortable with that. And with that, Monique, I'm going to hand it over to you. Thank you for being here today.
Thank you. Thank you for having us, allowing us to come and tell you what it's really like to live with someone with pretty severe mental illness. I have a now 16-year-old son that was adopted from foster care. He was born cocaine positive. He came into my home at about age 6 months, and his whole life has been a series of aggressive outbursts, antipsychotics, and fighting, continual fighting to get services for what he needs. He currently is in a residential facility where, for the first time ever, he's making progress. For the first time ever, he's learning to deal with the voices. Because he started displaying symptoms as early as age 3, I don't know that I've ever known my son when he wasn't in psychosis or having delusions. So the progress that we have seen him make gives us hope for the first time that there might be potential for him somewhere outside of an institution or outside of prison. What I wanted to talk with you about today was turned completely upside down because of a phone call I had this morning, just a couple of hours ago, hearing that he is to be discharged in mid-November. That discharge date puts him 6 weeks from completing this program. 6 weeks to cement the skills that are just emerging in him. I saw him at Labor Day. He's 9 hours away. We drive to see him. For the first time, I was able to say, well, what about the voices? Are they bothering you? And he said, well, you know, Mom, they do sometimes, but you know, I've got to learn what to do in spite of that. Are they still scary? Sometimes, like when I was trying to move to this side, they kept telling me I wasn't good enough, I wasn't going to make it, I'd never get out of here. But I learned that if I can distract myself, I might listen to my radio or pick up a book. I can tune them out. I wanted to weep. He's never allowed me to talk about the voices and never even had an inkling of a way to distract himself. So to think that he would be denied these last 6 weeks breaks my heart. This has happened to us plenty of times in the past where he begins to make some improvement, so it must be time to go home or to go to a lower level of service. No one thinks that perhaps he's doing as well as he is because of where he is. We've been discharged when our only crisis plan was to call 911. We've been discharged when no prior authorizations have been put into place for medicines that required a hearing at a state level to get approval for, and yet we're told we can go home and pick it up from the pharmacy. These are life-saving drugs for my son. The difference between the police coming to our house and to a somewhat peaceful evening. We've been discharged when no one has ever asked, what is it like for my other at-risk kids at home? I have 2 other kids adopted from foster care. My daughter won't sit in the same room as my son. His older but smaller brother is typically his go-to for a punching bag. No one's asked about the other kids that are in our home. Nobody asks about respite. What does the family need? We don't have caregivers that come in and out to help us. But in spite of all of this, I made a commitment to my son before my God, before a judge, that I would care for him. And having A psychiatrist even asked me, why have you kept him so long? Because he's my son. We work with him. We don't toss him out because he's not complying or he's difficult. Will those last 6 weeks guarantee success for him in this program? I don't know. But I sure know we don't have much of a fighting chance if we don't give him that option. So I'm here to ask, who in this room can help me? Who can stand with me to get him 6 more weeks of care? I know he's a high utilizer, an outlier in cost, but for the first time, this is personalized care for him and what he needs. If we spend more money now, perhaps he won't be readmitted. Perhaps he won't spend another 4 consecutive months in an acute care setting because there was nowhere to send him. Providers wouldn't come to our home because of his level of aggression. Providers couldn't come to our home because the closest RTD stop was a mile away from our house, and they had to walk a total of 6 hours between the bus and walking, 3 each way, to work 2 hours with him. We had no one to help, but we're supposed to take him home. So I need help. I need to know who can walk with me, walk beside us to fix the system, to make it better for him and for the kids that are behind us and around us who don't know how to fight nearly as well as some of us in this room do. I appreciate any help that you can give us.
Carol.
It would be marvelous to see him have a hope for that future that every mother wants for their child to have.
Uh-huh.
Thank you.
Oh, God. Oh, God. Oh, really?
Prior to today, it would have been rhetorical. Today, it is real.
Mondays and Wednesdays work for me.
If our team can help
Wednesday.
navigate.
Thank you.
Sorry. Let me turn down my webinar.
Thank you, Monique, for sharing
Mondays
your
and
story, and
Wednesdays work.
sorry the system
us.
hasn't been working for you like it should be.
Wednesdays only work in the morning.
Before we move on to the next person, I just want to ask if you are online by phone or on Zoom, if you can mute yourselves, that would be great. And you can do that by hitting *6. The mute button on your phone does not necessarily work, so please mute yourselves by hitting *6.
6 more, just.
I want to check in. Is Deborah Cave with us?
I'm on the phone.
Oh, great. Deborah, if you want to start your testimony, that would be great.
All right, let's do that.
Thank you. But you're right, somebody's on the phone and it's hard to hear.
Got it, thank you.
I'll work on seeing if I can mute them.
All right.
Okay, thank you. Okay, my name is Deborah Cave. I'm the Executive Director of the Colorado Coalition of Adoptive Families, or COCAF, and I would be glad to talk with Monique after this is over if you're able to give her my phone number. We advocate for Colorado's adoptive and kinship families at all parts of the permanency process. One of the primary issues in which we support families is to access appropriate and timely mental health care for their children. Children are entering foster care with significant trauma, including in utero exposure to toxic substances, emotional, physical, and sexual abuse and neglect, genetic predisposition to mental illnesses, and multiple moves in care. And these are the same children who are then being placed either with kin or who are being adopted. The outward expressions of trauma that these children exhibit are very difficult for our parents to both control and address. Generally, by the time that I receive calls requesting support, these families are in crisis. And I absolutely need to emphasize that this is despite the fact that they have accessed all customary available mental health services. Adoptive parents tend to be very proactive in identifying their child's mental health needs and in seeking supports, including utilizing therapists, psychiatrists, school supports, non-traditional therapies, and in-home services. Unfortunately, for some of our children, these services are not enough. When I mentioned appropriate and timely mental health care above, that also includes the need for residential care in some situations. Provision of mental health services is a continuum, and it must include services for those needing the highest level of care. I actually hate to use the term residential care because conversations usually shut down at that point. But it or a less restrictive but appropriate placement alternative, for example, therapeutic foster homes, must be available as part of a mental health continuum of care. It's not appropriate for families whose children are in crisis and meet this level of care criteria to have to wait months for access to it. It is not appropriate for the only option to be placement out of state, where family support and interaction with a child will not be therapeutic. It's also not appropriate to have this level of care constantly denied to a family, even when the family has completed, sometimes multiple times, less restrictive services required by the mental health provider and which the child has shown no improvement. There's a process where denied services can be reviewed by an independent evaluator through OBH. In the several cases I've been involved in this, the independent evaluator in every case disagreed with the service provider's decision not to provide out-of-home access. This absolutely needs to be addressed. Finally, although EPSDT process can be invoked on a case-by-case basis, where a doctor determines that it is a medical necessity for a child to be placed in residential care, there are several problems with this. Number one, the definition of medical necessity is not clear. We were working with one family where the provider actually changed it during the process that they were working with the family and did not even inform the family of that. Number two, implementation of the EPSDT process is not transparent at all, and in many cases, or most cases, the parents are not even aware of this option. And number three, in no way should it be used in place of a comprehensive, standardized approach in addressing the need for residential care for this at-risk population. Thank you.
Deborah, thanks for sharing that. That's really helpful information to know. We really appreciate it.
Thank you for letting me speak.
Okay, Phoebe Norton, are you here with us?
Thank you so much for having us here today. We really appreciate the opportunity to talk with you. My name is Phoebe Norton, and I am a retired executive director of the Community Mental Health Center, the public mental health system at that time for Boulder and Broomfield counties. And I want to tell you a little bit about my background. I grew up with a sister with severe schizophrenia. That was many years ago. She's dead now. But then when I was in college, I worked in an old-time state hospital with 3,000 people in it for the service area of Cleveland, Ohio. I was on the 3 to 11 shift as an attendant, moved around to different wards, as they were called. I might be the only attendant with 88 people on the ward, figuring out how to manage that and having to swab the floors and make sure they got fed and all that sort of thing. And I saw horrible things in that state hospital. I saw people tied to potty chairs, chain beds. I saw children even mixed with adults. It was absolutely horrendous and worse than anything you've seen on a movie such as One Flew Over the Cuckoo's Nest. And it wasn't bad because the people were bad, the people that worked there. I thought it was a traumatic situation, both for the residents and for the workers. And I hope we never go back to it. And I decided then that I wanted to devote my life to keeping people out of institutions of all kinds, including jails, prisons, large institutions. Of course, we need good, small hospitals, but this is an entirely different game. And I have devoted my life to that. And so then when I retired from being the director of our public community mental health system, which was the way I saw it as a public system, I joined the National Alliance on Mental Illness because some of those NAMI members had come to me when I was director, and they put a lot of pressure on us. You need to have more housing. You need more residential care. You need more respite care, whatever it was, for children and adults, etc. And we always tried to join with them to do that and join with other systems to do that. And it was in a time when the funding was more direct, simple, and more flexible. So we were able to do a lot of innovative things with other systems. With the National Alliance on Mental Illness, then, we see this as a great opportunity for Colorado to really reform a system that's broken. And it's not just our system that's broken. It's broken across the United States. And I really recommend reading Bedlam by the psychiatrist Rosenberg from Cornell University. And it's about the people in jail across our country. And if you read the recent ACLU report, you know that's true still here in Colorado. And again, I don't think it's anybody's fault. I think people are well-intended at all levels, but we need a major restructuring. So anyway, as part of that, Judy Amabile, who's here with me today from, my time up?
Go. They can't hear you on the phone, so
Oh, okay.
possible.
We're going to present the results. We wanted to make sure that National Alliance on Mental Illness had a voice. And so we did the survey that you have in front of you, and we got 58 responses. It was a pretty open-ended survey, and we have a really dynamic chapter of NAMI right now. And so this outlines what people saw in this survey. Might see as an ideal system. And how much? 2 minutes. So I'll just go over this a little bit, and then Judy will continue it, give her time. I just want to add during 2 minutes that we do have a proposal for how we might restructure in a big way our whole behavioral health system that Judge Balin, who is our recently retired Chief Judge, Sheriff Pelley, Joe Pelley in Boulder, and I have put together, and we have the endorsement of our local NAMI chapter. And we want to present that, and but this is not quite the right forum for it. Can we do it in states? Thankfully, and Michelle's suggestion, Summer is going to meet and present that, and we'll try to figure out a way to get that to the task force as well. And we've already talked to a number of legislators. Nearly 79% of the survey respondents said the payment issues affect their decisions about acquiring treatment, not surprising. Services that work well are our mobile psychiatric emergency services and the co-responder emergency services with a mental health worker and police officer going out together. And then Mental Health Partners, which is our current community mental health center, and is helpful to many people if they have a consistent psychiatrist and mental health worker. Now, that's very tough. I'm sure you've already heard about the workforce issues these days, particularly psychiatrists and prescribers. It's very difficult for us to recruit them and keep them in our public system. Brief hospitalizations, like 72-hour holds, are generally not helpful because people are not stabilized well enough, and often information is not shared between the inpatient and outpatient providers. This has become worse, really, and just under the commercial insurance, hospitalizing people separate from maybe the ongoing care provider of the community mental health center. It's become a little more fragmented. Incidentally, all of this were from the responses we got. These are not my ideas. My ideas are in the other proposals, along with Sheriff Pelley and Judge Balin. But these came from our, I bet my 2 minutes are up. Okay. Well, I would just like to turn this over to Judy Amabile. She's one of the young, dynamic people we have as part of our local National Alliance on Mental Illness chapter. And we provide, I know you all know, we provide free education and support groups. It's the bargain of the century, in my opinion, that are presented by peers, very well trained with templates that are evidence-based. And it's a wonderful thing. So I think Judy Amabile is next.
Yes, Judy, you are up to testify, so if you want to come on up. And while you're coming up, what I'll say is, Phoebe, thank you. And I think if we can get a copy of that survey, and if you're comfortable with it, we can post it on our webpage so that others can see it as well.
Okay, so my name is Judy Amabile, and I am on the board of the National Alliance for Mental Illness. in Boulder County and Boulder and Broomfield counties, and I'm also on the Board of Mental Health Colorado, and I'm on the policy committees for both of those organizations. And she's running for our state legislature. And I'm running for the state legislature. And I have a son who has a serious mental illness. He has schizophrenia, he has co-occurring substance misuse, and so we have spent the last 10 years trying to figure out how to get him help, and we have found the system to be woefully inadequate in serving the people for whom it is designed to serve. Although maybe it isn't actually a design, it's just an accident that it ended up this way. I helped with the focus groups that culminated in this survey, and so I can give you a little personal color on the survey results. I want to just go back to this. Brief hospitalizations are generally not helpful. My son has been in and out of M1 holds numerous times, and they really don't work. And there is, in the statute, the ability for somebody to stay longer, but in the real world, it just doesn't happen. And it would be helpful for many families to get your person stabilized before they get released. And then, of course, the other thing is that once they are released, there's no follow-up. So you go, you have an M1 hold, maybe you spend 2-3 days in the hospital, and then they tell you, come pick this person up. And they don't have a plan. They don't. Oftentimes, they don't have another follow-up appointment with a psychiatrist. Our son got released from Highlands Behavioral Health on a Friday afternoon. They put him on a new prescription for a drug that we could not get anywhere. We called every pharmacy in the Denver metro area and could not get that prescription filled. He didn't even have one pill in his pocket. He just had a piece of paper. And within 3 days, because it was a holiday weekend, he was back in the hospital on a suicide attempt. So I think there's some regulations around that could be put into place that would be fairly straightforward. And I do hear sometimes, well, we have that. But in fact, you don't have that. We don't have that because it happens all the time. It's happened to me and it's happened to other of the NAMI members. What many people want who have a kid with serious mental illness is for there to be a hospital stay that is followed up by supportive housing with wraparound services. So you go from the hospital, you step down to a place where a residential facility where somebody makes sure you're taking your medications. They get you to your appointments. They help you with your job. And you stay there as long as you need to stay there, not as long as the insurance company wants to pay for you to stay there. Insurance companies should really not be able to practice medicine, and right now they do, and they do it poorly because their incentives are perverse. Then you could step down from that into Section 8 housing or some kind of housing that isn't as intensive as long as there continues to be follow-up services. And we heard that from a whole bunch of our members. We want to have integrated treatment for your mental health issues and your substance misuse situation. And then the other thing, and I know this is very controversial because I've launched it at meetings that some of you here have been at. The family is the primary caregiver for most of these people. And the family has absolutely no ability to interact with the caregivers and to get a voice in their treatment. And I understand that some people don't want their family to be involved. And they absolutely should have the right to say, I don't want my family to be involved. But for many of us, our people aren't well enough to know whether they want us to be involved. And we are involved by default because they live with us and we're taking care of them and we're keeping them alive, but just barely. And it would be hugely beneficial if there was a mechanism for the family to have a voice in the treatment. And I think the other thing that we heard was our educational system doesn't address mental health issues soon enough, doesn't identify mental health issues effectively, and that might be a place to start. I think all of us who have a kid with a serious mental illness spend a lot of time looking back and saying, maybe I blew it. Maybe there were signs. Maybe if I would have done this or if I would have done that, things would be different now. And so we would like for the next generation of families to not have to spend that kind of time on the look back, because there are probably some proactive things that could be happening that aren't. And I guess the other thing that we hear from families is there's a lot of shame and blame. And that is hard to take. And part of the reason it's so hard to take is because we're already ashamed and we already blame ourselves. And so we don't need the system to continue to foist that off on us. That base is covered. We're taking care of that ourselves. So that's my input on our survey. Thank you.
Thank you, Judy. Next, we're going to ask Janet. Do you want to come up and join us? That would be great.
Hello, my name is Janet Vanderlock, and I am Mac's mom, advocate, and voice. And I have an adult son. His name is Matt. He's 27. He was diagnosed with chronic paranoid schizophrenic in 2014. He's been in the judicial system, low-level offenses. He did have some felonies, but they were dismissed due to competency. And right now he's actually sitting in jail. Friday is his 28th day. That will be the 28th mark, waiting for a competency evaluation. Prior to that, he had spent 84 days languishing in jail for waiting for a bed, and until I reached out to Representative Jonathan Singer and the Colorado Disability Law Center, I was able to get him a bed for competency restoration, which restoration to me is just another word for just having them recite what they're being. It's not even, they don't get restored, they still come out sick, right? So it's just another day, another form of collecting money, because it's $667 per day that they stay every time, per day per inmate at the mental hospital in Colorado. So why did it take 5 months for them to restore him? I mean, these are the issues that and questions and concerns that I have. Right now, the last year he was on mental health hold for 8 different times. When he did come out of the state hospital, he was released in January of 2018, and when they released him into, or this is one of the times that they released him back to jail, and when they released him from jail, they dismissed all the charges, but when they released him from jail, he didn't have a bridge prescription, no resources. He lives with us. I had to take him to my primary care physician to get a 30-day bridge prescription. He was court certified in December of 2018 on a 6-month court certified gravely disabled for 6 months through MHCD. MHCD dropped him, which is the biggest contradiction ever. How do you drop somebody who's gravely disabled? How do you deny someone services like that? He also was denied services because when he did come out of Pueblo, the intake coordinator at MHCD told me that he can't get services because they're waiting on what the pending charges are from his probation officer. He just came out of the state hospital, and you are waiting on what the charges are to get services. So we're leaving out a huge vulnerable population that we're not treating, which is the gravely disabled and the severely mentally disabled. It takes 4 to 6 weeks just to get an intake. And my son has to do that, which intellectually he's not capable of doing. And they told me that it's because of HIPAA laws, but then how come I can make an appointment for my husband at the dentist or his family physician, but I can't make an appointment for my son? That to me needs to be changed. And we need to remove mental health reentry programs out of the jail system, because this is what happens when you pair jail, police with mental health services. This is what happened at the RISE program at Arapahoe Detention Center. They released him from, this is another stay. This is the first stay. He was at Pueblo for 5 months. They released him. They had already dismissed the charges, but yet they still sent him to jail at Arapahoe County in the RISE program. And I got a call from the director, Wallerstein, saying that my son was on a mental health hold for a suicide watch. They said he did this to himself on a 24-hour watch, 15-minute check-ins. My son didn't do this to himself. His MO isn't suicide. It's chronic paranoid schizophrenia. So that's one thing that we need to do. Second of all, the intakes at MHCD, why are they taking so long? Why is it 4 weeks? That's just for the intake. Why? And then an additional 2 to 4 weeks just to get seen. And then if you miss your appointment or you don't have contact with your case manager for 90 days, then they drop you. Why? Why are they doing this? That's my question. And MHCD has their hands in all kinds. They're a nonprofit, so they get tons of funding, and they have their hands in all these pilot programs, right? But what are they doing? Why can't they consolidate those programs and use that money for what it's intended for, to help the severely disabled and the gravely disabled? And why did they? There's 455 beds in the Pueblo State Hospital, right? So that's supposed to cover the whole state of Colorado? Why? But yet MHCD keeps getting funding and funding and funding. Fort Logan dropped from 222 beds to 94. Why aren't they using that funding to increase those beds? Those are the issues that I'm having with MHCD. He did have a great case manager. Her name was Hannah DeGroat, but the policies that prevent her to provide services don't allow her to do what she's supposed to be doing. So my son right now is sitting there waiting on a competency evaluation, and I spoke to Dr. Rye in the past, and he said that there's 300 inmates per one nurse. Does that seem right to you? I mean, our jails are the #1 mental health service provider right now. People with mental illness spend... No, at the city jail. And, okay, it's inmates that have mental illness spend 5 times longer in jail than your average inmate. So we really need to figure out how we can do better. And thank you very much.
Thank you, Janet. And you're right, we have to figure out how to do better. Thank you for being here.
Hello, I'm Michael Campy, and I would ask just for some checks and balances for therapists and other professionals who prescribe medications for depression, anxiety, and so on. I have some lived experience, tried to commit suicide a few times, and I almost succeeded with an overdose of drugs for anxiety. What a little bit of history. I know drugs have a a great purpose for a lot of people. My brother's a paranoid schizophrenic. Without medication, he would not have nearly the quality of life that he has currently. There's a lot of people. I was 10 years as a culinary instructor for the Lookout Mountain Youth Service Center in Golden, and there were prescriptions given to some of those juveniles that really benefited them. But in many cases, it was kind of also, I thought, used as a behavioral management tool for security reasons in some cases from my observation. Also, a lot of those kids, you know, they did really great in the culinary program, and a lot of them went on to succeed. Some of them still call me and reach out, you know, that they're doing well, but a lot of them don't. And a lot of the folks that were on medication there would eventually get released from juvenile corrections, and then they would have just not a lot of support, or they would only have a certain amount of medications that they become dependent on to function. And when those ran out, and without the support, moral support, and many times would wind up back into negative situations because they couldn't get a job and so on. And then when the drugs ran out, they were really screwed and wound up back in adult prisons. I was involved in the task force by the Equitas Foundation for Mental Health and Criminal Justice, and there is a big need. They have a great suggestion for some things, but for me personally, I went to a lot of different therapists with different insurance companies over the years, and I just always thought it was anxiety, and so I would just get a prescription, you know. I told many different therapists from different insurance companies with the different jobs I had over the years that I was an addict as well. I had problems with drugs and addictive personality, and that wasn't really addressed until after I almost died, and then I finally, thank God, got a great therapist that could really help. And the first thing was, let's deal with the addiction, you know. So here I am with this freely given pleading to a dozen different therapists, and either them or the nurse practitioner would just give me another prescription. So I had so many. I remember one therapist, like, I would talk for 10 minutes. You still doing drugs? Yeah. And then I wouldn't have anything else to say, and they would take my $90 and, do you want to make another appointment? So I think really what I would ask is that there were some checks and balances for the prescriptions, maybe tie them together from doctor to doctor some way. It's also a problem with, you know, a lot of the prescription drugs in America today, but yeah, it was just so many prescriptions kept changing till they thought that was the cure for me. So it really was more of detriment for me. So when I tried several times, and finally I had all these pills in my bookcase that I decided I was going to do it for sure. So I did all this research about what pills I had in my bookcase that were old prescriptions that would make me sick and which ones would kill me. So I took about 300 pills, and the doctor told me when I came to a week later, had I taken my high cholesterol medication, there would have been no way they would have saved me. Well, I didn't even look at that one. That seemed like an innocent one, you know. So with the grace of God, I'm still here. I've done the peer support specialist training. I've been involved in a lot of different things trying to help other people. You know, it's true. The families are just crying. They don't know how to help. But the main thing I would ask is that there was some focus on the drugs, because for me, you know, when I finally came out of Porter, I was at St. Anthony's and then Porter. The first thing was like, give him more drugs right away, you know. And I said, no, I'm not taking them. I haven't been on any drugs for 3 years. I refused them in the hospital. I refused them in my intensive outpatient program. And I haven't had any, and I'm clear. You know, I'm focused, I'm helping other people, and that's just for me. The drugs have a critical role, don't take me wrong, but they're not the fix-all. And it seems like that's working in youth corrections for 10 years, it was an easy thing. Just give those behavioral people drugs. And then when they leave, like some other people have mentioned, they don't have, all of a sudden they have to cope without them. They haven't learned how to cope without them. So I think with lived experience, my perception is try to put some collaboration with all of the prescriptions some way, because you could go to different doctors and it could be pain medicine or anything. For me, it was, you know, it was the anxiety pills, and then I didn't even think I had depression, but that turns out what it was. And so anyway, put a handle on the drugs would be a good start. Thank you.
Hi, everyone. My name is Mary McRae. I'm with Heart Mind Connect and Aubrey, and NAMI Public Policy Committee. Heart Mind Connect is starting supportive housing. I'm happy to say this was from my personal life experience with the lack of that. And I think that she's looking for the video. She'll let me know we're done. So this is Diane. I lost my best friend of 32 years to suicide, in which she came to the ERs to get help, and they failed her 4 times, the last time saying there were no long-term treatment beds that they could find for her. I also want to mention in remembrance of young adults that we've lost in my small personal circle. Micah, 24, Chelsea, 25, Ryan, 22, Kevin, 20, Russell, 25, Amanda, 21, and Shane, 24. Also, all lost to ER holds where their job should have been to give proper treatment, like any physical illness, to those that were critically sick with brain disorders. Even now, as I speak, 4 days ago, my son was released after his 5th M1 hold by Swedish Hospital, who failed to follow the law and released him even with the specific details from Mental Health Center of Denver's crisis team that they needed to find my son long-term treatment and not release him, as this was his 5th hold in 7 weeks with nearly fatal alcohol poisoning to drown out the voices from his schizophrenia. I believe we must immediately work on solutions where people are told to go to ERs and they're dying coming out of there. And they're dying to the tune of $25,000 per day. I mean, what could we do with this money? It's outrageous to me. The government has spent $500,000 on my son, and he's still in the same place because we stabilize, we don't do treatment. So I think that's just critical, and I can't possibly understand why this can keep happening in the hospitals, and we need to have alternative crisis centers that can actually do something to help people with psych beds. My son last summer had taken himself into St. Anthony's ER in Lakewood. They held him for 5 days, in which time he was left in a stark room without treatment as he decompensated. He was without a toothbrush, without shower, and meals had to be reminded to them. When I told them this was not acceptable, the response was they were terribly sorry, but they were a trauma unit and really were not trained properly for psych beds. Even the head of the ER, Mr. Goldstein, reiterated to me that he couldn't seem to get proper training to his staff for the psych beds. So all of the people that I mentioned earlier, my loved ones, were not ones who hid in silence with their illness. I can't do anything about people that choose to not talk about it or say I can feel horrible for them, and we can keep talking about mental illness, but these are people that came forward and in the system tried to get help for being critically ill, and they were let down, and their lives were lost. And we can talk about suicide prevention all we want. And that's fine maybe for a high school student that broke up with a girlfriend. And I'm not minimizing any of those situations, or I'm not minimizing them. Depression can happen to each one of us. But I'm talking about what are we doing for those that are severely mentally ill? What are we doing for them? And suicide prevention and all the money in the world can go into it. And we don't have treatment beds. We don't have options. It's just, I don't understand how money can keep flowing in all the wrong directions. And we're continuing to have such high suicide and mental health treatment flow. And I'm not proud of this state, of being in a state where this goes on. My son also had a horrific time trying to get a bed at Fort Logan. He was moved from Jeffco Mental Health Center to Arapahoe because Jeffco Mental Health Center stated that he was too complex. What does that mean? And there were more programs at Arapahoe. So moved him there. Then when he needed a bed at Fort Logan, they didn't have allotted beds there. And demographics should not play a role of somebody being able to get a treatment bed, whether you have schizophrenia at Kipling and Bowles or schizophrenia at Mineral and Santa Fe. Again, that's just, it's mind-boggling. I don't understand that. The lack of beds, again, as people have mentioned, is unacceptable. To have 93 civilian beds or 94 for 5.6 million people is an atrocity, and it's a humanitarian crisis. Again, my son, because of demographics, could not get a bed. And even when he did, the top doctors there sat down and told me, the psychiatrist, that he couldn't get the one-on-one that he really needed, that they just did not have the staff and the funding. So again, you know, stabilizing and not having treatment, and also gigantic is no continuum of care after they're released from the hospitals. My son had to be sent sick across the country to Connecticut for supportive housing after hospitalization. And I had a choice of over 60 facilities for young adults, and young adults, not, our young adults don't belong in a senior living, assisted living, which were the only options we even had there, and even those were full. So I had a choice of over 60 facilities for young adults, and again, could not find one in Colorado for his needs. Finally, I want to say, as much as I'm fully aware of the horrific crisis in the jails and those awaiting competency restoration, I would like to say that my personal life experience was extremely dangerous to himself and to others, and who went, which that must be very difficult. And I'm grateful he has awareness. But what good is that if the message to him is, well, he also has ACT program. You know, we have to take away his ACT program because the people in jails get first dubs on that. The people in jails get the treatment bed.
Hi.
And he gets it, and that he looked at me and said, do I have to be a criminal? Is that what I have to do to get treatment? Maybe I should be a criminal. So, and I hear your story in the criminal justice system, and it's horrific, but I want you to understand that my story is horrific, and my son is denied programs because we have this huge issue, of course, with those in jail, with those out of jail, the civilian beds, and with my son trying not to get in the criminal justice system. Oh, okay. You want to play? Okay. So that's it. This is a video I did when my son left St. Anthony's, and when I was basically in the parking lot crying because I couldn't get him a bed. Tell me there's a reason
me turn it up.
Is there something stronger in this person that I see, who does everything he can but can't break free? He's crying out, he's drowning in a wave that just keeps pounding, and I just have to watch him sink again. Tell me there's a reason for this suffering I'm seeing. I just need to know that there's a bigger reason for it all. Is it love demanding some greater understanding of the souls who get forgotten by the world? Think it's time we listen to this battle that we're missing for the ones who've lost their shields and have no swords. Maybe they're the chosen ones to change the ways that end so wrong as one more beating heart just stops again. I need to know a reason for the suffering I'm seeing. Tell me that there is a bigger reason for it all. You're crying out, you're drowning in a wave that just keeps pounding, and I just have to watch you die again. Maybe every tear that falls fills a well of some resolve that flows from something deeper in the end. There's gotta be some reason. I just need to know that maybe there might be some other deeper kind of meaning that transcends. I need some kind of knowing just to keep me going. Tell me that there is a greater reason in the end.
Thanks for letting us all come. I'm actually here on behalf of Developmental Pathways. We're a community-centered board, serves Arapahoe, Douglas County, and the city of Aurora. And so we are today talking about folks who have intellectual disabilities as well as a secondary diagnosis of a behavioral health need. So we've talked with a lot of families. We deal with a lot of individuals, adults, kids, families, foster care, everything you can think of. But it all has to relate to intellectual disabilities. And we've had a lot of families who are struggling because they're working with somebody who has the dual diagnosis. And the biggest thing is that when you've got a dual diagnosis, everybody says, nope, you got to go over there and you got to go over there. So the fractured system is our biggest concern because families don't know where to go and they're frustrated on that. They've talked about how much time they spend and they feel like their time is their money, and they're trying to find a provider, and they find someone who can actually provide them service. They get in there and the person struggles, knows how to serve a behavioral health or a mental health need, and doesn't know what to do with somebody with an intellectual disability. So our first request is, when you're looking at this system, is to figure out how can we do some incentives or training to get more providers who are able to do dual diagnosis services. And then with it, looking at the wait lists. So we have a lot of families who are just like, I'm great, I've got somebody on a wait list. But again, you've probably heard this also, even without the intellectual disability, it's with the wait list, what do you do in the meantime? And so we got families who are there, and they're struggling when their situations have to progress to an emergency status before they can get services and supports, or they hit the emergency status, and as soon as they're off the emergency status, they're no longer the priority, and so they get kicked out of a service. So that's one of the biggest issues as well, is not having a priority service for something when the families are trying to get their needs met before it is a crisis, before an emergency happens. And so we have set up a crisis system in our agency and a crisis supports, and we go through all of that funding that we have, and we're grateful for our mill levy to cover it, but it's hard. That mill levy is limited, so it doesn't meet all the needs. So first thing that we wanted to say is provider capacity is very limited for our families. We'd like to have, again, recommend some training or incentives so that we can get folks who are professionals who also have the intellectual disability background. We also would like to talk about some access to supported services. One thing is we have siblings and parents, caregivers who have mental health needs or behavioral health needs because of the person that they're caring for with an intellectual disability. So even if services are covered by Medicaid, if somebody's on a waiver, oftentimes their siblings start having troubles. We've got lots of siblings who have depression from it, and they can't get services because they're not on a waiver, and their insurance doesn't cover it, or all of those things. So we'd like to recommend also that that families can get services, that somehow we can create a system where families who have somebody with a disability can get services off of their Medicaid or off of somehow, so that the families aren't struggling anymore with that. Trying to pit which child do I care for first, or how do I care for my brother when I'm struggling on my own too. So looking at that, how do we get a system where we can serve the caregivers as well? And again, getting those incentives so we can create and develop intellectual disability and mental health provider base and medical professionals who can do all of those things as well. Our families are looking for more diversity in therapists, more locations, which is probably a very common thing as well. They're calling around. We've had one mom who called 40 psychologists and left 40 messages. We're not allowed to give recommendations on who to call, so we can give them a list. And she called 40, talked to one, got a message from one, and neither of them served kids. So she's still at stage one of, where do I go? I've got the Medicaid to cover it, but I don't know who will take care of my child. And so that's one of our access to applicable services. She has the way to pay for it, but doesn't have access to anything. So we'd like a system that's going to help share with families who is eligible to cover you. We'd also like to see, that goes along with the affordability as well. We've got families who are paying out of pocket for services because they can't find something covered by their Medicaid waiver. And so they're looking at, let's just pay for this out of pocket because it's not considered a crisis, but affordability issues, how do we cover that? I'm not sure how the state does that, but we would like to recommend looking at some system that helps get these services to families if they can't find a Medicaid provider. How do we pay for that then when they need somebody to take care of them? For residential, we've got not enough beds for residential services. Also, it's very difficult when you've got an intellectual disability. Where's the right place for you? And so we need some more systems or no more beds for that. So looking at a state system for residential treatment of people with IDD and mental health is almost non-existent. And so we need the regional center to be expanded, and treatment should include children. And we are struggling with continuity of services. So families who are on private insurance and then they go on to a waiver and they have to switch all of their providers because now they're on a Medicaid waiver. And this is a real struggle when you've taken years to find the right provider, and then you go to Medicaid and you can't have that provider anymore. So we need a better continuity of services from insurance to Medicaid for folks who are going to be getting services for their lifetime. And looking at that, how do we get that? So we've got the suggestion of payment streams that are simplified, public and private streams simplified, providing training or support so that we can have more providers who are interested in serving. I'll serve all of these insurances and Medicaid, whichever it is, so I can provide my services to the folks who are coming to me. So that's one of our suggestions there, to help with continuity of services and affordability and cover the insurance and the Medicaid piece. We're also looking at suggesting a fully funded public guardianship system so that we've got adults who need support. They've got someone who can help them through. We believe that will help their continuity of services. when they've got somebody who is able to take care of them when they don't have a designated family member who can do it. If we've got the public guardianship, then we can have somebody helping them through the system and helping them before they drop off and out of the system. And so we don't want them dropping off anymore and getting into the crisis stage before they get supports. And I know that's already in the works, but we're pushing, please, let's get that all the way in. And then last one, for the emergency psychiatric services, we've got families who, again, they're struggling because they're not at the crisis point, but they know that that's where they're headed if they don't get the services. And you know that the services are limited until you hit the crisis point. And so we're looking at how can we expand services that way. We've got families who've been turned away from hospitals because they're told, oh, this is an IDD issue, not a mental health issue. And again, they're fighting back and forth. This is both, or it's one or the, somebody just come. And so they're at a loss for what to do. How do we get that system corrected so that we can have, it doesn't matter whether it's the mental health or the IDD, we've got somebody here who's going to take a look at you and figure out what needs to be covered. We don't want people turned away anymore from the short-term or long-term placements, but specifically for emergency psychiatric services, we need capacity expanded at the Pueblo Mental Health Institute for violent non-compliant offenders who cannot safely be in the community, whether it's mental health only or intellectual disability and mental health. That's a real struggle of enough placements for them so that we can keep them safe as well as the community safe. I believe those are our points. We asked a lot of families their input, and so I've got little stories and quotes. I'm sure you guys have heard all of those different pieces as well. But again, I just want to reiterate our main recommendations are incentives to create and develop intellectual disability mental health provider base, including medical professionals. State system for residential treatment of people, adult and children, with intellectual disability and mental health. That a regional center should be expanded and treatment should include children. That we need a fully funded public guardianship system implemented statewide. We would like to see payment streams, public and private, simplified, and that training is provided so that other people can join into a different stream if they're only in one at the time. And that we see capacity should be expanded at the Pueblo Mental Health Institute for violent non-competent offenders who cannot be safely integrated into the community. So thank you so very much.
Thank you, Donna. Yeah, thanks for sharing the specific recommendations. I'll add just at the Safety Net Committee meeting last week, we shared a pinwheel of the 64 different funding streams that we have in Colorado, and we often talk about the fact that there's no wrong door, right? Well, that's 63 wrong doors if you don't go through the right one. So that's the problem that we need to fix. So thank you. Okay, let's go ahead and resume. Thanks everyone for accommodating so we could just take a quick break. Next on our list is Charles Davis.
Hi everyone, my name is Charles Davis. I'm the Chief Executive Officer for Crossroads Turning Points. We're located, we're based out of Pueblo, Colorado, but we do serve 21 counties. And so on behalf of, we have 235 employees, and annually we serve about 6,000 individuals each year. And just a breakdown to give you an idea, we have about 4,700 admissions in our withdrawal management clinics. We have over 500 residential admissions a year. We also have around 300 individuals in our MAP programs. We have 3 methadone programs throughout southern Colorado, one in Lamar, one in Pueblo, as well as one in Alamosa. And so when I signed up to speak to the committee, I went back and reviewed the minutes, and I found that this committee is hitting a lot of the issues that providers like Crossroads face. And I just want to highlight some of them for you. And by the way, this is my 29th year in the field. I started as a part-time bookkeeper and didn't realize I would be in the field this long, but it's been a passion that has grown, and my former mentor really instilled in me the importance that these individuals need our services, and sometimes even when they don't know they need them. So it's up to us to make sure that they happen. What I would tell you is that the SUD, substance use disorders, it doesn't have any targeted populations. It doesn't have any people that it likes to favor, any social economic classes. We see individuals from all corners of our communities, and it'll take any opportunity it can to impact people. And so we see a wide range, everything in ethnicity as well as income, as well as religious backgrounds. It's diverse, and so it presents a very a struggle and a challenge to our clinicians to try to meet all those demands. But I think our staff do a great job. One of the areas that we've been focused on for the past 17 years is the co-occurring services, and that's mental health and substance abuse being delivered, integrated in a setting. And we saw tremendous value in that. We saw people that would get their addiction addressed, but then their mental health would kick back in. And then they would cycle, and they would bounce back and forth. And then we would work with the mental health centers, and they couldn't address their mental health issues while they were under the influence or in their addiction. And so we kind of saw this ditch happening where people weren't getting treatment from either one of us for a variety of reasons. So with the advent of the co-occurring models that came out about 1999, 2000, our former CEO really pressed us to look at it, to bring it to Colorado, and make sure that we were ahead of the curve because they were having such good outcomes. One of the places I can remember is in Memphis, Tennessee. There was a program that was doing great things. And so for 14 years, we funded co-occurring by private grants and foundations because we were ahead of the curve in the funding models. There's a substance abuse block grant and there's a mental health block grant, and that's how it was back then. And unfortunately, that's how it is today. Those things have not integrated. They have not come up with any rates that cover what we do. And so we still struggle to make that happen. And so we have clinicians that, again, we're billing and getting funding based on our SUD rates, even though we're providing this integrated model. And I think it's one of the areas that this committee could really help move forward and look at that. We recently added the Circle program to our menu of services. It had been discontinued a couple of years ago, and we were able to revive that. The doctor that had been running it was on the verge of retiring, and we knew that if we didn't save it, it was going to be gone. And so through the help of OBH and CDHS and Signal Behavioral Health, we were able to basically resurrect it. And it's been in operation now since January of 2019, and it's having wonderful outcomes. And it's really become a staple for those individuals that have severe behavioral health issues. It's a 3.7 for those of you that know what that is. For those of you that don't know, basically it's a medical model intensive residential program that runs about 90 days. And we've had about 60 discharges, and I think we've only had 5 discharge unsuccessful out of 60. So we're having great success with it at the preliminary part. Obviously, it's more important to measure down the road, but the initial indicators are that it's a great program. I think one of the things that and you guys just mentioned before the break, is the funding mechanisms. When I started back in the 90s, there was 3 basic models. There was a 1/12th model where we got paid just to do encounters. And then there was a fee-for-service model, which was a minor model. And then there was the line item model, which basically they gave us an amount of money. We basically told them how we were going to spend it. And then we billed based upon reimbursement of spending the dollars. And those models have all changed. They're gone. They gave us great flexibility, but at the same time, the evolution of moving to a more accountable system was inevitable. But I do miss those days because we did have a lot of flexibility on who we could help and how we could help them. There was never enough money to go around, but it did give us the ability to help folks that were in great need. And again, it wasn't based on their income or based solely on what part of the region they were in. 1 minute. I will make it quick. So one of the frustrating parts that I want to get to that we have is the co-occurring models rates. So I would encourage the committee to look at that. I would also look at the rural. I think I saw in the minutes you guys talked about rural versus urban, and that is a huge challenge. I think probably 14 out of the 21 counties we serve is either rural or frontier. And so we recognize that some of those counties and communities don't have the greatest number of needs, but they do have the need, and it's not always based on cost per widget if it's worth it. So they are much more expensive to work in, but they do have legitimate needs. And so one of the advances we're working on is telehealth to help clinicians serve more areas and be more productive. And that's coming along, but it's taking a while. The only other thing I would tell the folks is the multi-tiered with Medicaid. There's these built-in cliffs that people get better up to a point, and then they've got to make a decision. Do I go off Medicaid and lose my benefits, or do I, hang on? It shouldn't have to be that way. There should be a stair-step process so that if they can start helping pay, if they can start getting things done, they shouldn't run into a cliff where they just have to fall off and carry it themselves. We don't do that anywhere else. We shouldn't do that in this kind of treatment. Lastly, I just want to thank the committee from our board, from our staff. We know you guys have tackled a huge task in trying to reshape the behavioral health system, and we'll do everything we can to support you. Thank you.
Thanks, Charles. And thanks for the good work that you're doing. It's much needed and much appreciated. Sure. Is Mike Austin in the room? Mike, do you want to come up and share your testimony?
A little bit different.
Make yourself at home.
When I called and I said I only have 10 minutes, I did a radio interview back in Michigan. They gave me an hour and they had to cut me off. So anyways, no, I'm Mike Austin, and I don't have the brochures and all that kind of stuff. What I have is just life experience. I'm coming from, we talk about depression and substance abuse, and I'm not ashamed to say it. I mean, I've been clean and sober for 18 years, so I'm very familiar with that lifestyle, and I work with a lot of jail inmates as a result of that, going in and carrying the message, of hope on a weekly basis. And the depression part, how that affected me, I mean, being drinking for a lot of years and stuff, that's depressing as it is. But my wife, she suffered from depression too, and she was sober too for 30 years. But she lost the battle to depression, and she shot herself. She committed suicide November 20th, 2017. So 52 years old. So it's real. To hold on to a dying person is not something that's pleasant. But I made a promise to her. I said, you didn't die in vain. So when I saw this, it's like, you know what? I'll go any place and speak anything, and all I have is from the heart, and just say, I see the struggles. I do. I'm involved in a prison ministry in Sterling. We spend every other Saturday in maximum lockdown talking with men, and you talk about some stuff. It's not how bad, and I want to hear your stories. As it comes down to this, and what I found is, people just they want somebody to listen to them, and that's what we do in there. It's called agape love. It's called listen, and love. And so these men want to talk, and being, inmates too, and depression. I mean, like my late wife and stuff. She was so ashamed of it. She was being treated for it. I mean, it's not like she slipped through the systems, but toward the end, I'd always say, hey, you want to go get some help? And she said, what am I going to tell them? There's something wrong with me, And it's like, Well, I said, well, that's for them to figure out. I mean, that's for them to figure out. So, and I was telling this young lady over here, I got talking with her and stuff, I'm a retired senior maintenance tech from Ball Corporation, okay? So I was a fixer. I had buildings and things to fix. And I would joke with, and I'd talk with people. I said, how do you get anything done? I said, all you do is meetings, day in, day out. Meetings and meetings. Now you got another meeting. And I understand that process because I was involved a little bit in the budgets, but it got frustrating sometimes, and I'm sure for you guys too. I mean, I'm on the level of going into Denver County Jail on Mondays, okay? And I go into Adams County Jail. That's real. And these guys, I talk with them. I'm not a psychiatrist. I talk with them about my experience. And there was one of the companies there at Adams County, they withdrew their mental health services. And these guys are saying, we're screwed. They were really helping us. And when you're sitting in a jail cell, you don't have a lot of options. You don't have a lot of phone calls. And they're asking me, and I'm going, I don't know. I don't know why they withdrew out. I mean, there's, I heard the rumor that they ran out of money, And so, I know that from your guys' top level, that it trickles down, But like Saturday, I'm going to be sitting in Sterling Prison with these guys, and I love them, And they're asking for help. Not like, from you guys coming in. I'm sure that they have mental health stuff in there. But that's kind of the level, and that's why I came down here, just to share, I mean, my life was forever changed on November 20th. I didn't ask for that change, I didn't, and I'm sure that, a lot of other people, have been affected by that. There's not a whole lot of families out there that has not been affected by addiction, mental illness, or suicide, and I guess that's my lot in life anymore. It's kind of like sometimes it's like, and so when I get a chance like this to come down and just say, hey, I mean, it's real, and I mean, I thank all of you people for doing what you can do, and from the bottom level down, we're trying to get these guys into treatments or whatever, halfway houses, and stuff like that. So, I don't know all the politics of it, I mean, I don't. But, I'd be more than glad to talk to anybody or whatever, just from the street level, I mean, from somebody that's trying that, and so, when I talk with the people, I'll say, hey, I got a chance to put my 2 cents in, and before I got in here, and I'm not, and I'll say it, I said a prayer, and I said, Teresa, I said, this is for you, honey, this is for you. So she's still helping people, and so I don't really know. Yeah.
Can I ask you a question, Rick?
Sure.
And I'm sorry about the loss of your wife.
Thank you.
Thank you for sharing that. Since you get an opportunity to work with people in the prison system, and Sterling's a huge prison system, do you have any feedback for us on how we can do a better job supporting the men and women in our correctional facilities?
I'm still kind of new in there. I would love to have some information for you in there. They do have a Celebrate Recovery that has started in there on the minimum side, and that's a 12-step faith-based program, and that's one of the programs that I'm involved in. So I really don't have any information on that. It's hard to, when you go into a prison system, to start talking to people. You got to be so, hey, how's your mental health and stuff? It's like, huh? I mean, great place. But I wish I could answer that, have a little more to you, So, but like in the jails, as I said, in Adams County, there's, one of the places that, and what really took a big hit last year or the year before is when Arapahoe House closed. You guys, yeah, and I used to go in there. I mean, and I still go in there. It's called the CRC now on Thursday nights. But we went in there for 13 years, the one up in Thornton. And when that closed, well, I tell you, a lot of people took a hit. It was the ripple effects, like, what are we going to do now? Where are we going to take these people? So that's coming from my level. I'm sure you guys probably hear that kind of, and all we know is, like, why did Arapahoe close down? I don't know. I mean, I'm not asking you, but it was a place where, that people could get some help. So, you know, I mean, we still have the Denver scares we call it Denver scares. Yeah. You know, but, yeah. But I mean, any more, questions? How much time do I have? Because I can go.
You're kind of out of time, so.
Oh, you should have said something because. Yeah. See, I should have said, you know what? When you want me to shut up, somebody walk up here and just stop my hands and I'll stop talking. But until then, well, I want to thank you for your time and stuff, you know, for doing that. Right on.
Thanks for giving back, Mike.
Thank you.
Thank you. Next, we have Ashley Brock-Baca.
Thank you for this opportunity to speak. My name is Dr. Ashley Brock-Baca, and I work at the Colorado Office of Behavioral Health as the Trauma Responsive Service Array Developer. But I'm here today as a parent. Raising a child with a mental health disorder presents daily challenges. Common childhood mental health disorders affect activities like learning to read, paying attention in school, making friends, and organizing homework. The good news is that with appropriate therapy, education, and supports, children with mental health challenges can lead successful, fulfilling lives. The bad news is that the appropriate therapy, education, and support are almost impossible to access in Colorado, even for parents with substantial resources. My oldest child is 8 years old, and she is curious, sweet, talented, and very intelligent. She also has ADHD, and the challenges we have faced obtaining appropriate therapy and education for her are an embarrassment to the state of Colorado. I will discuss 3 categories of challenges that I have personally experienced as a parent: mental health treatment, education, and parent supports, starting with treatment. I have spent countless hours online and on the phone trying to find a psychologist for my child who sees children, takes insurance, and has openings to see new patients. This is virtually impossible. Trying to find a therapist with specific skills or treatment modalities is even harder. Currently, I'm paying $150 out of pocket for every 45-minute session that my child has with a psychologist who doesn't take insurance because she's the only provider I can find without a waiting list. Weekly appointments add up to $600 a month. We have been on a waiting list for 3 months at a clinic that takes insurance, but no mental health clinicians have openings for new patients. In addition to the difficulty of finding a therapist, insurance restrictions are incredibly limiting. My insurance company is willing to pay for a lifetime of psychotropic medication for my child, but they won't cover 20 sessions of neurofeedback therapy to try to improve her attention or processing speed. Insurance also won't cover the cost of any of the skill-building activities or sports that therapists recommend for children with ADHD. Despite research showing that outdoor exercise is as effective for ADHD as stimulant medication, but with only positive side effects, insurance won't pay for the soccer league fees, the running club registration, or the sports gear that is needed for the 8 hours a week of structured physical activity that is recommended for children with ADHD. The second major category of challenges is finding appropriate supportive education for a child with a mental health challenge. My child attended full-day kindergarten at a school with 30 students in a class with 1 teacher. This experience was so overwhelming that she actually regressed academically and socially, having started kindergarten with excellent foundational skills. Literally, going to public school kindergarten made her worse. So starting in the 1st grade, we moved her to a private school where she's now in the 3rd grade in a class of 10 students. After 2 years of small class sizes and individualized attention and support, she's finally achieving academically what is expected of a child of her intelligence. But the expense of private school tuition is crippling, and this option is out of reach for almost all families. Parents should not have to take their child out of public school to get their mental health needs met. All children, and especially children with mental health challenges, need healthy relationships to thrive. Relationships with teachers are critical, but no teacher can manage healthy, supportive relationships with 25 or 30 students at the same time. Kids with ADHD, anxiety, or other mental health disorders are not going to thrive in this environment. Teachers also cannot manage the number of IEPs, 504 plans, and behavior intervention plans with a class this size. I believe schools cannot realistically comply with IDEA laws with the large class sizes that we have in Colorado. Colorado's public school funding is an embarrassment. We are number 38 in the nation in per pupil spending, despite the fact that the cost of living in the state is the 17th highest in the nation. Colorado teacher and school mental health professional salaries are at rock bottom. You can't be an educator in the state unless you have 2 extra jobs, a trust fund, or a wealthy spouse. My sister moved to Colorado a few years ago to do an internship to finish her master's degree. When she graduated, the starting salaries she was offered by Colorado schools were all around $31,000 a year, with a master's degree and a clinical license. So she did what any reasonable person would do. She moved to a state with a starting salary 50% higher and a cost of living 30% lower. This same decision is made by countless graduates of Colorado universities every year. The third challenge raising a child with a mental health disorder is accommodating their needs and supporting skill building in the child's everyday life. This is monumentally important, and it requires a lot of skill on the parent's part. When parents aren't attuned to their child's needs or don't have the skills to respond to them effectively, children's mental health problems worsen. Because I'm a psychologist myself, I have been able to develop these skills and implement strategies to support my child. But most parents do not have the knowledge or resources to do this. Parents need coaching and skill building, and some families need intensive supports, advocacy, respite care, and wraparound. Colorado needs a comprehensive children's behavioral health system that offers all of the supports that children and their families need. The problems I have discussed have devastating consequences for Colorado: human suffering, broken families, system dependency, loss of potential, and worst of all, suicide. But it doesn't have to be this way. Colorado ranks among the worst states in the nation for children's behavioral health outcomes. Most states are doing something different than we are, and we can do better. Colorado must invest in educator and mental health provider salaries that are commensurate with the high cost of living in the state. Furthermore, the state must invest in expanding the workforce of mental health providers and educators. After entering the workforce, providers and educators need ongoing training and support to ensure they have the skills to meet the needs of the children they work with. Colorado does not have a children's behavioral health system. There are no parts that work together in an organized fashion. A Band-Aid plan won't fix what's wrong. You will not be able to improve outcomes without addressing fundamental, systemic issues in Colorado's education system, and you need to create a children's behavioral health system because one does not currently exist. Please, I implore you, don't waste this opportunity. Colorado deserves better. It's time for real change.
Hi, I'm Dawn Martin, and I wasn't really prepared for this today, so I'm going to wing it. I own Recovery Unlimited in Colorado Springs, and we provide substance abuse disorder treatment and mental health treatment. And as of this morning, we had 550 clients that are active right now. I have at least 20 really educated and extremely talented therapists, master's level, PhD. I think a lot of the things that I heard here today, the bottom line to the issues is money. And what you were just saying about what people get paid as master level therapists, it's ridiculous. So we provide all low-cost therapy, sliding fee, underinsured, majority Medicaid. We got a notification last week saying that one of the Medicaid rates that we work for is lowering our rates by 20% in January. 20% is a lot of money, especially when you already work for really low rates. So this is the deal. We have HICPUP rates, and we knew that we were signing up to work for those rates. So then the rates come in, and they're private. So they can pay whatever it is they want to pay. So now they're paying, all of them are paying lower than the HICPUP rates. So we're asked as professionals to meet with people with mental health disorders and addictions and do an assessment on them, which usually a good assessment can take 4 hours. Like, we want to get in there. We want to know everything, right? We want to give it an accurate, good, professional diagnosis. $80. $80. There's a mental health group that HICPUF, in the HICPUF book, is $12.24 per person in that group, maximum 12. So I have to look at these therapists and say, hey, could you do this group for us for $20? I don't know what we're going to do come January. We are going to have to look at going private insurance and turn these people away. They come in begging for services. They are hurting. Parents that we've heard today, they're hurting too. But we're going to have to tell them no, because we can't keep getting our rates cut. We want to be the best mental health professionals that we can, but we can't keep doing it. I'm going to lose therapists in January. And we'll have to take and focus on private insurance. Most of the people that come see us, they don't have any money. They don't have any money. People with money get treatment. People without money don't get treatment because no one wants to be a provider because they don't get paid. It blows me away that every time there's a mass shooting, we're screaming for mental health services. And don't get me wrong, the demand is there. I have 3 buildings now. We did this in like 6 years. The demand is there because we want to stop it before another fatality happens. But we can't meet the demand with the rates we're getting paid. We have to get these raised to meet at least HICPUF standards. Come January, and I talk to a lot of providers, we have to dip out. And that is really, really sad to me. We have all of this funding coming down for opioid addiction, which we need. You know, there's a lady that lost 2 children, 2 boys in the same day from overdose. That is what's going on. It's busy. But we don't have money to pay the professionals to do what they need to do. So that's all I have. Thanks for hearing me today.
Thank you for explaining that. Some of y'all understood what's going on after you.
Oh, I hope I did that. Thank you.
Very well you did.
Thank you, Dawn. Thank you. Next we have Cheryl McNeil. Is Cheryl here? Betsy Casey? I know Betsy's on her way.
Thank you guys for giving me the time to speak today. My name is Casey Pittman. I'm actually the administrative manager over at Recovery Unlimited with Don Martin. I didn't really prepare for this, but I think this is so important I kind of wanted to say something. I've been in the field for about 9.5 years now. I facilitated groups, started programs, and facilitated individuals for DHS, state parole, federal probation, state probation. And I even taught at places like CAE and ComCorps, and I was even the gentleman whenever guys sent kites in to go and visit them at the jail. I have a deep passion for this field, and the main reason I wanted to come up here and speak was kind of what Dawn was talking about, is this 20% cut that we've been told is going to happen in January. And the reason why I bring that up is one of the main duties I have is trying to find therapists to come and help us with these contracts. And I'm not trying to come across like we're bragging, but we have now 20 therapists that we can successfully brag about. Ethical people who love to teach, who actually will sit and stay late to help out clients, do pro bono work when a client is in need. And we've even the last week have had 6 clients who successfully graduated parole who've decided to use their Medicaid to continue their services with us. I started a program called SDOP with state parole, where we have parole officers that are in the group with the clients, who are actually there to try to help these clients out, and they're even doing services with things like Phoenix Multisport, and they're already seeing successes, clients passing UAs, passing mouth swabs, asking questions, and staying late. And the hard part is keeping good therapists as it is already a struggle. It is. It's an unfortunate reality. And when we had to sit in front of these 20 therapists, these therapists that people are bragging about, our main assessor is to the point where the federal probation will only utilize him for their assessments. And they're looking at us going, if this happens in January, Casey, we don't know what we're going to do. And that's a tough thing to swallow. It's extremely hard to find ethical and people with that passion in this field. We're not asking for more money. We're not greedy human beings. What we're asking for is to be able to keep the rates that we have promised these individuals so we can keep doing the services that we do well. And I just at least wanted to sit here and say that I know there's a lot of stigma working with probation and parole clients. But if we can get past their masks and get to the root cause, I have seen success and I've seen great things happen. And I would love to continue to do that instead of seeing these amazing people go to places where, unfortunately, they're not helping this population out, and I feel like we would fail this population compared to how we're helping out other populations, which I think there's a great need for it. So again, I deeply appreciate everything that you guys are doing, and I wanted to at least say there are good things happening. I would really wish that we can continue to do these amazing things with the amazing people that we took a very long time to find. Thank you very much. That's all I really have.
I think we had some input from the Ombudsman Office, just to share.
Thanks, Summer. Since we've had two pieces of testimony from providers, we just wanted to share that one of the main charges of our office, which was put into statute by House Bill 181357, is to take calls from providers or groups of providers that are worried that there have been mental health parity violations, which include things like access issues and provider reimbursement rates and such. And so please, anyone who's listening or who's paying attention to this, if you want to talk with our office about it, you can reach us at 303-866-2789, or at the email cdhs_ombudsman_bh@state.co.us. My name's Rebecca Swanson. I'm the Deputy Ombudsman. This is Aubrey Boggs. She's the Ombudsman, and this is something that we are looking into. And we also have a statutory requirement from any of the regulatory bodies, at least in the state, that if we bring a potential parity violation to them, that they have to bring a response back to us. So we look forward to talking to people further about this. Thank you.
Thanks, Rebecca. Betsy Casey? I know she's on her way. William Henricks, would you like to testify?
Good afternoon. My name is Bill Henricks. I am President and CEO for All Health Network, a community mental health center serving Arapahoe and Douglas counties. Thank you for establishing a statewide task force to develop new directions for behavioral health in Colorado and for the opportunity to testify today. I have a doctorate in clinical psychology, a master's in business administration. I've worked in behavioral health for over 34 years. Throughout my career, I've operated or consulted on behavioral health services in 14 states, worked with some of the nation's leading behavioral health care organizations to create programs in a variety of treatment settings, including hospitals, schools, primary care clinics, outpatient clinics, and skilled nursing facilities. For the past 2.5 years, I've served as President and CEO at All Health. I believe my background gives me a unique perspective on what is happening with behavioral health services in Colorado and provides me an array of treatment models which may be helpful as we seek to improve access, cost effectiveness, and clinical outcomes in Colorado. Establish priorities. Focus is power. To begin improving the mental health of Coloradans, we must establish clear priorities and commit the resources to achieve them. If we choose the correct priorities, we can improve mental health and save money at the same time. This will create more resources to address additional priorities. One strategy is to target behavioral health conditions associated with potentially avoidable and high-cost medical services for aggressive intervention and management. According to data from HCPF, substance use disorders and mood disorders are among the top 10 conditions for associated medical costs. Prioritizing and successfully treating these conditions will likely result in substantial reductions in medical costs. Medical cost savings could then be used to address other behavioral health priorities. This is exactly the approach we are taking at All Health Network. We are creating specialized intensive outpatient programs, one targeted at substance use disorders, one targeted at depression, with a focus on reducing clinical symptoms as well as unnecessary medical costs. We believe our programs will create substantial reductions in medical costs, savings that can be used to address other behavioral health priorities in our region. Stabilize and streamline behavioral health funding. Behavioral health funding in Colorado is unstable and highly fragmented. At All Health Network, for example, our model of payment through the state has changed significantly and repeatedly in recent years. In terms of fragmentation, we receive revenues from nearly 300 funding sources. This includes both government and commercial payers. Often funding changes are made with little or no warning. Given this instability and fragmentation in funding, it is distressing, but not surprising, to hear consumers report concerns about trouble accessing services or gaps in clinical care. In addition to establishing behavioral health priorities, I encourage the state to consider opportunities to stabilize and streamline funding across the state. Learn from other states. Lastly, I believe there is much to learn by looking across the country to identify potential solutions to the behavioral health crises we face here. Here are just a couple of examples. The Depression Improvement Across Minnesota Offering New Directions model, or the DIAMOND model. While many states struggle to integrate behavioral health with primary care, Minnesota has been doing this successfully for over a decade. The DIAMOND model has improved access, outcomes, and reduced overall health care costs. Second, prioritized list of health services. Oregon's prioritized list identifies health care services most highly associated with improved quality of life and reduced health care spending over time. Treatment services for substance use and depression are consistently near the top of Oregon's funding priorities. As a result, access to key services has improved, and the overall medical cost for Medicaid beneficiaries is significantly reduced. In closing, I thank you for the opportunity to provide behavioral health services to Coloradans in Arapahoe and Douglas counties. I look forward to partnering with you to identify priorities, stabilize and streamline funding, and learn better ways to meet the behavioral health needs of Coloradans across the state. Thank you very much.
Thank you. And William, I'll ask if you have contacts in any of those states that you think it would be beneficial for us to talk to. Yes, that would be great.
Good afternoon. Oh, I guess I should ask, shall I start?
I'm going to move the microphone a little bit closer.
Oh, sorry.
Okay. You could, just continue projecting to there.
Okay. Good afternoon, ladies and gentlemen of the task force. My name is Betsy Casey. I am the program director of Building Hope Summit County. It is a nonprofit founded in 2016 to create a more coordinated, effective, and responsive mental health system in Summit County, Colorado. Thank you for taking the time to listen to my testimony today. Building Hope has 9 program areas created to seeking to improve residents' mental health and our system in Summit County. One of them is a scholarship program, and I will be sending you guys, I have a couple of associated documents that I will be emailing out for your review. The Building Hope Scholarship Program was launched in July of 2017. It was created to ensure that no Summit County resident was denied access to care due to a financial barrier. Since the program's inception, the program has provided 781 unique scholarships and paid for over $300,000 worth of care for Summit County residents alone. The program was designed in a way to always be a pair of last resort, with insurance navigation integrated into the screening process. Our staff and issuing sites undergo training to ensure that whenever possible, people are connected to mental health care through an established payer source first. To date, Summit County experiences among the highest insurance premiums in the nation. Despite having a perfectly good payer source and paying some of the highest premiums in the nation, 54% of scholarship recipients, of our Building Hope scholarship recipients, have insurance. and cannot utilize their insurance for a myriad of baffling reasons. I will be outlining some of those in a moment. We meticulously collect data on all scholarship recipients, including type of insurance and barrier they are experiencing to utilizing their insurance. As a small startup nonprofit, it is not only unrealistic for us to continue to pay for residents' care when they have insurance, but we are continually shocked at the barriers that our clients face on a daily basis when attempting to use their coverage. To put it into perspective, an average scholarship and insurance navigation phone call takes anywhere from 20 to 60 minutes, teaching the resident about the many hoops that they must jump through in order to utilize their payer source. And approximately 75% of one FTE, one full-time employee, is devoted solely to this work. Chart 3 indicates, sorry, you guys don't have chart 3 indicates the barriers scholarship recipients face when trying to utilize their insurance. We've collected data on 454 recipients, which I will share with you. So again, I would like to point out how ridiculous it is that 54% of our recipients are receiving scholarship when they have a perfectly good payer source. So let's talk about barriers. Fit and selecting a therapist. In order to be a client-centered model of care, empowering somebody with the choices of who they can work with is an important part of the process when getting connected to care. Most of our scholarship recipients have never sought mental health care, so when they finally take the brave step to select a therapist that looks like it could be a good fit and obtain the same values, it can be a really positive moment. Most of the time, we have to tell them that the provider that they've selected does not take their insurance. We tell them that they have to work with the provider that is selected for them. We send them to the pre-selected provider of their insurance, and 72% of the time, those people call back because that provider was not a good fit for them. For those of you who are unaware how therapy works, therapy is effective because of the positive relationship formed between a clinician and client. And in order for therapy to be effective in any way, shape, or form, there has to be a good fit. Therapy is not effective because of treatment modality, but again, because of the positive relationship that develops between the client and the clinician. This is not the same as a physical health care provider. If you don't like your doctor, it doesn't really matter. It's not going to affect your care that much. If you don't like your therapist, you are going to get zero work done. So when we try to connect somebody to care and they go to meet with one or two of the providers on their network and can't seem to develop a relationship, does that just mean that they're out of luck? No. The Building Hope program follows the science that says that they should have the ability to connect with someone that works for them and to really follow that best practices, that the fit is the most important thing. Many times this can take a few visits and a few providers, and the horrible network inadequacies make this virtually impossible for people in Summit County. Network inadequacies. This is yet another barrier. 17% of providers in Summit County currently accept insurance. 17%. This number is very scary for us when we are trying to get somebody connected to care. The likelihood that those individuals currently have openings is almost zero. I built this program and have personally approved every additional session request that we can, and for acute cases, high needs, and complex trauma, we usually approve twice the sessions of regular recipients. But our program can only sustain so much. I cannot tell you how many cases I have seen, like children with complex trauma, men and women struggling with addiction and using therapy to remain sober since we lack formal treatment programs up in Summit County, suicidal teens, mothers and fathers with major depressive disorder trying to get well for their families, individuals desperately needing care, all of them who have a perfectly good payer source they cannot use. The provider will not accept their payer source because of tedious paperwork requirements, reimbursement rates that are completely unsustainable, and getting reimbursed sometimes up to 8 months after care. One provider was so upset wanting to support one of her families, but was stuck between either not working with this family or receiving a $35 reimbursement rate from UMR. $35 for her 60-minute session. And that's a licensed, credentialed, a licensed professional counselor. I understand, and I can tell you, I understand that I can tell a family to call the Ombudsman office and file a complaint, but do you know what that sounds like? Your child is suicidal, and you can call this number and file a complaint. It is incredibly difficult to tell that to a family. I go home at night and wonder where our families are, how our residents are making it work. And I believe that you all believe and that we're here today because mental health is not a luxury. Mental health care is not a luxury. This is an absolute necessity, and I'm wondering what our friends are doing at the state level to hold insurance companies accountable and make violations like these held up in a court of law. What are we doing with insurance companies about network inadequacies? It's shocking to me that they can get away with listing a provider on their panel who is deceased, dead. We actually had 2 providers who were actively listed who had died, many of them who have moved away. Or insurance companies have several providers listed and they are all completely unavailable. Also, do you know what it takes to get a provision to then see an, do you know what it takes to then get a provision to see an out-of-network provider? It takes knowledge that you can even do that. Getting on the phone, negotiating with someone from the insurance company, trying to explain yourself and explain why you could not get care with the in-network provider. For those of you who know what it's like to have a mental health challenge or even a crisis, a person's ability for ration, logic, and reason is literally taken offline because their mind is compromised. So you're asking someone to navigate a system where they have no previous ability to be able to do that when their brains or their mental faculties are offline. Oh, great. Okay. Essentially, I wanted to talk to you guys today a little bit about what we're all doing to hold insurance companies accountable and what is happening in order for those processes to happen. Building Hope is currently in the process of looking at some innovative strategies to provide billing management platforms and actually use grant-funded billing management FTE and hire a grant-funded position to be able to get more panelists credentialed. Also, I just wanted to take a moment to say that I currently have insurance and I pay $550 out of pocket to pay every single month for my own mental health care because I was not able to find the right fit with a therapist who could be able to deal with complex trauma. So this is not only something that I advocate for our own programs, but something that I personally also experience today. And I am happy to also send you guys the documents so that you guys can take a look at the way that we have collected our data and how we remain to do so. I am very grateful for the opportunity to be able to share with you guys, and if you have any questions, I believe Summer has my information. Thank you for taking the time to listen to me.
Thank you. And please send those documents. I'll make sure to circulate them. Thank you so much. Running a little bit ahead of schedule. Sharon, would you like to come on up?
All right. You ready? You can hear me okay? All right. Good afternoon, and thank you for this opportunity to address this respected group. What you are doing is quite ambitious, important, and valuable work for our state. My name is Sharon Raggio, and I come to you today wearing multiple hats. First, I come to you as a mother. I'm the parent of 3 sons with mental illness, each of whom was adopted out of the foster care system as an older child. I have lived experience and understand firsthand the impact of trauma on developing minds and personalities, as well as the impact of the families who love them despite the trauma and their mental illness. I also come to you as a mental health professional, having worked in the field for over 40 years. I'm a licensed clinician and the CEO of Mind Springs Health and West Springs Hospital. As a mother and as a professional, I'd like to share with you some thoughts. I want to address 3 main points: day-to-day successes and challenges, workforce, and what is needed. So first, as a mother, I know the anguish of a child not getting the help they need when they most need it, and no parent should ever have to suffer that way. It's just not right. But that's the way it really used to be on the Western Slope. People in psychiatric emergencies and crisis suffered unnecessarily in unsafe places, sometimes for days, because psychiatric hospitalization was unavailable to them in their most desperate moments. This because there was only one psychiatric hospital, which we operated, but it was a mere 32 beds, and for the last 3 years, there was a wait list for a psychiatric hospital, a wait list. Staff had to make unimaginable decisions on an hourly basis. Who needs the bed the most? Is it the young boy who's actively suicidal? A teenage girl experiencing a first psychotic break? A young mother who's in a hospital ER and has been there for 2 days? It's untenable, and it had to change. With the support of many, many Western Slope community members, the counties, and the hospitals, and some of Colorado's most generous mental health advocates and foundation, a new 64-bed state-of-the-art environment was built, and the new West Springs Hospital opened last December in Grand Junction. I am very grateful for the many partnerships that made this success possible, and for our donors who contributed $18 million. I'm really also proud of the partnerships that allowed the design of the hospital. We included our patients in the design of the hospital and really got some great feedback from our patients. The new hospital is trauma-informed and is actually winning some architectural designs awards nationally for its state-of-the-art design. On the other side of my organization, I want to talk about a family in Summit County. This has to do with some innovation, rapid recovery models of programming that our organization piloted about 3 years ago, and we've since enrolled it into all of our counties. We started off with depression and had a cohort of about 250 people, and the results are pretty impressive. But I want to tell the story of a mom in Summit County. This is a mom with a young son who's now 12 and in 6th grade. Last year, he tried to complete suicide, and his mental health was so tenuous, his mom felt he could not leave him alone, ever. He was in the hospital on the Front Range and needed local services to stay safe, but traditional services had not helped him so far. So we follow our organizational mission of delivering quality care and hold the value of continuous improvement close. We developed an accelerated recovery program built around best practices, and it decreases psychiatric symptoms more rapidly than traditional outpatient programs. For instance, at week 6 of the program, 63% of the participants are out of their acute phase of illness and into recovery, and by week 12, that number is 78. Again, this has been data collected across multiple disease states, depression, substance use disorder, and in this example, children and our adolescents and their parents. I'm really proud that our organization garnered national attention, and we received the 2019 Institute for Healthcare Improvement Award for Patient Engagement. Because as the last speaker said, it is all about the relationship, and this is really team-based care. So you have a whole team of providers wrapped around you that you can rely on regularly. This mom and her son participated in this new recovery accelerator model, and ever since, she's been telling us and others how it's dramatically changed the lives of the entire family. She says she gets chills when she thinks about how far her son has come and how her family has come together in ways she did not think was possible. More good news is that she and her family are not alone. We have rolled this out into all of our locations across our 10-county area, and we have rapid recovery now, quick access, and more open doors. So those are just 2 stories of where I think the system works. But there are barriers. What seems to be the new normal in behavioral health is a serious workforce shortage at all levels, from frontline receptionists to licensed professionals and to psychiatric providers. Because of this, we are now competing nationally and with the for-profit world. I would state that this really has just changed in the last year to this degree of significance. Used to be that we could recruit people for the Colorado lifestyle, and we have some gorgeous Colorado areas, but that is no longer true. We are now competing with large metro areas, and the salary demands are jumping 20 to 30%. Due to the demand and shortages, we are competing with the East Coast and the West Coast, which pay big bucks. So the salaries for child psychiatric specialists are now $310,000. Oh my gosh, it was $180 just 10 years ago. But that's what the market requires. $290,000 for generalists. Nurse practitioners are about half that rate. Clinician salaries are also up, about $65,000 to $70,000 for a generalist and $75,000 to $80,000 for a specialist. We are unable to afford these salaries due to all of the payment, be it the state, be it Medicaid, be it commercial insurance, no matter what it is. Our reimbursement rates today are not keeping up with the market. Our base unit cost payment methodology that we are reimbursed by does not adequately represent the cost of care in this fast-changing market. This is new, but it's real, and it's also a year in arrears by the time it's looked at. Our local FQHC partners, hospitals, and even lately Department of Human Services hire candidates our organization needs at a higher salary and without the paperwork that community mental health centers have. All right. So when it comes to retaining staff, we found that administrative burden is the #1 reason that people leave. I know you've heard about this. A 21-page required intake flies in the face of good care, and filling out forms to make sure that people are mentally ill enough or substance abusing enough in order to receive state funding is immoral. Our clinicians despise this practice, and our funding is very siloed. We can do better. So how do we improve our system? I offer the following insights. First, build on existing strengths. Colorado has a system, albeit an imperfect system, in its community mental health centers. This network of talented people are consistently seeking ways to innovate and are excited to partner with the state to improve and continue to evolve in meeting the needs of Colorado. Eliminate siloed funding and reduce the administrative burden. Realize that all care is local. What is needed and appreciated in Aspen is very different than what is needed or appreciated in Grand Junction, much less Denver, Colorado. Invest in prevention. We must find a way to get upstream, or we will be hosting task force meetings every other year. In rural Colorado, regions do make sense. There must be some shared infrastructure to gain efficiencies. Incentivize outcomes instead of processes. Today, mental health centers receive incentives for process measures such as the person being seen 4 times in 90 days. Instead, think about outcomes. Did their symptoms decrease? Do they report feeling better? Did they use a psychiatric hospital or less? Think about triage. In physical medicine, we triage as a matter of practice. We have routine care, urgent care, ER rooms, and specialists. We don't have that system in behavioral health. The mental health centers are the state's specialists, yet we are overrun with the expectation that we should be all things to all people, and we cannot. It takes all of us together. Think about triage. Review what other states are doing. There's a national movement of certified community behavioral health centers that many states are adopting. This model eliminates siloed funding, creates more of a triage safety net, clearly defines administrative burden and reporting, and reimbursements are done differently and are at cost. And lastly, as our last speaker spoke about, we have to have true parity. Create true parity. A robust mental health offering is often 3 sessions, 3 outpatient sessions. 3 outpatient sessions is EAP. It is not a robust mental health offering from an insurance company. It's just not acceptable when it comes to behavioral health. Thank you for your service in working to improve the state's behavioral health care system. It's gratifying to know that we have a shared vision of accessible and quality behavioral health care for people in need. Thank you for the opportunity to speak with you.
Thank you, Sharon. If you're comfortable leaving a copy of your testimony, that would be great.
Actually, let me email it to you because I've got some handwritten marks.
Perfect.
I want to get through it.
That'll work. I appreciate that. Thank you.
Thank you guys all. Good to see you.
I'm not seeing anybody, so I think that is a wrap for today. I just want to thank everybody who testified today, who shared their story and experience and recommendations, and many thanks to the task force members and subcommittee members who were present today and listening online. We really appreciate it.